Hello, and thank you for joining this OncLive peer exchange titled Multiple Myeloma, Emerging Concepts in Management. Life expectancy for patients with multiple myeloma has increased significantly over the past 20 years. Additionally, we continue to evaluate novel therapies to achieve deeper responses and improve outcomes for patients. In this OncLive peer exchange panel discussion, my colleagues and I will provide our personal perspectives on the new research, new combinations, and new agents available to us. We'll review the data from ASH 2017 and the impact of what has been presented on how we treat our patients with symptomatic disease. I'm Dr. Keith Stewart, the Vasek and Anna Maria Pollack Professor of Cancer Research at the Mayo Clinic. Participating today on our distinguished panel are Dr. Cristina Gasparetto, an Associate Professor of Medicine and Director of the Myeloma Program at Duke University Medical Center in Durham, North Carolina. Dr. Hari, Professor of Hematology at the Medical College of Wisconsin in Milwaukee, Wisconsin. Dr. Robert Orlowski, Chairman of the Department of Lymphoma and Myeloma and Director of Myeloma and Professor of Medicine at MD Anderson Cancer Center in Houston, Texas. And Dr. Nupur Raj, Professor of Medicine at Harvard Medical School and Director of the Multiple Myeloma Program at Massachusetts General Hospital in Boston, Massachusetts. Thank you so much for joining us. Let's begin. Bob, I'd like to start with you. Nowadays, it has become clear there are many different types of multiple myeloma with different and variable outcomes. I was interested to start our discussion in how you work up a patient at MD Anderson with respect to risk stratification.
Yeah, great question, Keith, and thanks for having me on the program, by the way. Definitely fluorescence in situ hybridization or FISH studies on the bone marrow are a standard of care now, especially because you need the results from the FISH to do the staging, because the revised ISS system includes either deletion 17p or translocation 414 as one of the factors that could flip the stage upward. And you also have to do a lactate dehydrogenase level. And then gene expression profiling can be very helpful as well, because there are some patients, for example, from older data with deletion 17p who you would think would be high risk, but if they have a good risk profile by the GEP data, that can actually indicate that their prognosis is better. So the benefits of doing this assessment are, number one, you get a better analysis of the stage, and you can provide the patient, number two, with a better estimate of their prognosis. Although right now, we're not yet at the point where we routinely do different induction therapy based on the risk, many people now will do different maintenance therapies, as we hopefully will get to later in the program. And there are now some risk-adapted studies that are underway as well.
Let me ask the rest of the panel, do you treat patients differently based on their genetic risk score, or do you feel it's just interesting from the prognostic point of view? Harry, what do you think?
Thank you, Keith. I totally agree with what Dr. Orlowski just said, that induction doesn't really matter at this point based on risk. I kind of tend to think in my own mind that a younger person, especially with a high-risk profile, needs to get into a molecular MRD negative stage. I think the attainment of an MRD negative state has been shown to be particularly significant for those people. So that in that way, I try to tailor treatment towards getting there as quickly as possible for those people.